Hello, everybody, and welcome to our webinar today. For those that don't know me, my name is Sue Verley, and I'm the Regional Education Coordinator at the Northeast Ontario Stroke Network, and we're happy to bring this talk to you today. I'll just remind people, if they have a question, you can put it in the chat at any time. I would also like you to change your name on your screen, as well as put your email in the chat, and that way we can ensure you get your certificate of attendance and the handouts of the PowerPoint following the session today. We are recording, so I can put it on our YouTube channel for those that need to access it at a later date or that weren't available to be with us today. I'm going to get right into introducing our speakers and get on with our talk today. So I'd like to welcome Teresa Gwala and Carrie St. Jean. Teresa is the National Lead for Program Development and Clinical Integration at Vision Loss Rehab Canada. She's an occupational therapist by background with 35 years of experience in clinical practice, program development, and operations management, and she works out of Ottawa, Ontario. And Carrie is the Senior Manager of Healthcare Operations and Specialized Projects in Ontario at Vision Loss Rehab Canada. She works out of the Sudbury office and has held a variety of roles throughout her career with Vision Loss Rehab Canada and the CNIB. Welcome, ladies.
I'm very pleased to be here. So glad to have this opportunity to talk about what it is we do and how we're going to be able to hopefully work together with the facilities in the Northeast. In addition to what Sue just shared, Carrie is the local regional manager, so she would be the local contact if you have questions. And as she said, I'm the national lead. And I do a lot of work in terms of developing and integrating some of the specific and specialty programs that we've developed within our organization. So today we're going to talk about our organization, generically what it is we do and the people that work for our organization, but we'll also be touching a little bit more specifically on stroke and the opportunities or challenges of clients who have stroke and vision loss. So the first piece is VLRC and low vision and some of the challenges in terms of gaps and prevalences and functional challenges, etc. So one of the things we always try to do is help people understand who Vision Loss Rehab Canada is. Many know of us as CNIB, but we are no longer CNIB. CNIB continues to exist. CNIB has done this type of work for over 100 years, but at a certain point, they recognized that having funding model based on fundraised dollars was no longer sustainable. So they worked and obtained funding through the government in all the provinces except Quebec. And once that had occurred, excuse me, they established Vision Loss Rehabilitation Canada as a separate organization that provides all the rehabilitation and healthcare. So VLRC has existed since 2017. In 2018, we formally launched into with a new board of directors and a new company. We serve, as an organization, we serve clients who have low vision and blindness. Visual impairment, essentially, that can't be corrected either through medical or surgical treatment or standard eyeglasses. So to that end, if I took my glasses off, and I would actually qualify, but since I put my glasses on and get relatively perfect vision, then I do not qualify. So someone could be wearing glasses, but essentially if it's not correcting to the level where they would be able to see well and function well, then they would be eligible. When we talk about having medical or surgical treatment, there are clients such as retinitis clients or ARMD clients who could be receiving medical care, but they can still come to us. So the idea is that usually that care, that surgical or medical treatment is not necessarily going to correct their vision. It's going to prevent further deterioration. So they will continue to be challenged with from a functional point of view. So that visual impairment that they have, the second part is to it that somehow it impacts their safety, their independence, their ability to function. And that could be very wide ranging. It could be anywhere from reading to being able to get around inside their home or in the community, etc. Low vision is quite prevalent. 1 in 20 Canadians have a problem with low vision. That prevalence increases. So, and as our population is aging, we're seeing more and more people who do have low vision. On top of that, 85% of those Canadians who have a vision disability also have two or more comorbid conditions. Things, and that's one of the reasons we're talking about stroke, but it could be anything. It could be a high blood pressure, could be a cardiac condition, could be diabetes. Often it is diabetes. And so they're trying to manage not only the vision issue, but the other conditions that they have. I don't know how to get rid of this thing, so hopefully you can't see it, but anyways. So some of the issues that rise, there are, of course, all of us see gaps in our healthcare system, but it's a little bit more of an issue when it comes to vision rehabilitation because we tend to exist outside of the healthcare system. Vision care is often provided by the ophthalmologist or the optometrist, both of whom are generally not heavily integrated into into the healthcare system. They're more the primary care instead of the family health doctor for low vision. And so that sort of lack of integration of the healthcare system with the vision care system causes an issue. There's often poor transitions between areas, particularly when a client is admitted into hospital and then going home. There's not a very good transition in terms of involving specialists in low vision to ensure that that client who has difficulties with their vision is able to go home safely and securely and independently. There's a lack of awareness. Those who provide healthcare generally don't know what vision loss rehabilitation is and or have a different understanding. And so we don't necessarily even get those referrals because it's not well known what it is we can do. And there's limited access, there always is. We're one organization that's covering all of Ontario, and many clients who have low vision have trouble getting from wherever it is they live to wherever it is there's a clinic or a specialist providing that care. The decreased visual function can have a significant impact on function. And some of the areas that they can have difficulties are just daily function. Being able to prepare food, being able to choose their clothes, being able to read instructions on a pill bottle, use a smartphone, a computer. Our world is very visually dependent. And clients people who have a vision loss often struggle with a lot of activities because of that. It can impact a safe and accessible home environment. If you really can't see well, or if you have low contrast, it's going to be have difficulty going up and down stairs. Stepping into white bathrooms with white grab bars is going to be trouble. Lots of challenges. Orientation and mobility. People are usually more comfortable in their home because they know it well. But once you start stepping outside of that home, either within your apartment building or out into the community, orientation to the surroundings and your ability to mobilize can be significantly impacted. And understanding and adjusting to that vision loss. It's one of our 5 major senses. As I said, our world is heavily visually dependent. So being able to adjust to that loss and understand what that means, it's a lot. And lastly, those who are younger, working age, or recent graduates, being able to retain work, go to school, those are all big challenges. How does stroke impact? So stroke actually has this pretty significant impact on vision, and it can impact at different areas. So it can impact the actual function of the eye, such as being able to constrict the pupil. It can affect the extraocular muscles so that you don't have good control of that eye. You end up with things like nystagmus or drift or double vision. It can impact on the visual pathways from the eye to the brain, so along that optic nerve. And it can also impact at the occipital area and the visual processing area of the brain. All of those areas can be impacted by a stroke, and all of those areas can lead to different or multiple types of deficits in vision. The prevalence of visual impairment is high. It's studies have put it at least 65%, potentially 70% of stroke patients have visual impairment. And often it's not recognized, and often it's not addressed. If you're performing stroke rehabilitation, you're probably very well aware that it tends to focus on motor movements, on language and communication, and not a whole lot on vision and how vision would impact that ability to recover. If visual deficits are seen or addressed, it's usually limited to those ones that are obvious, things like a strabismus, hemianopsia. We've all heard of hemianopsia or hemianopia. Sometimes if there's a significant visual perceptual, that'll be picked up. Sorry, I just want to see if no, I didn't. Okay, but some of the more subtle changes, things like scotoma, where you've just got a partial field loss, you've got spots here and there, or you've got a loss in contrast sensitivity issue or glare sensitivity issue, a perceptual thing where an agnosia, where you're not even understanding what it is you see. Many of those pieces are not picked up and not addressed early on in stroke. Sorry. Sorry about that. Okay. So here's just some pictorial examples of what we're talking about in terms of visual function. So here's this one here, double vision makes it difficult to read. So many clients do have a double vision. Here's someone who's really sensitive to bright light or a glare coming through. Here they've got, this is a significant central vision field loss. Here's less significant, but still that blurring of it and difficult for you to be able to recognize someone who may not have seen often, to be able to interpret visually what someone's thinking, but also be able to read, follow a recipe, etc. You can also get things where the vision's there, but it's twisted. Here's an example of contrast sensitivity. So we've got stairs where you can actually see the edges and you can see your hand rails, versus someone who they're not able to see those details. So for them, it just looks like one long ramp, very difficult to pick up individual stairs, and it will lead to real difficulties with mobility and hesitancy to get out and walk and move around. Their gait patterns will actually change because their vision has changed. So just some examples. As you can see, here is someone who potentially has this loss in contrast sensitivity, and they're being very cautious going down those stairs. So with the development of our own company, our new company, and we looked carefully at how we could deliver the services more effectively. We took a long time to work with our different clients, different groups who had input into it, and came up with a new service delivery model. I'd like to tell you about it a little bit. So it's basically, as you can see, a pyramid with the bottom being client navigation. And as you go up, the issues become more complex and occur less frequently. So every client has client navigation. Actually, I'm going to let Carrie talk about this a little bit because my voice is tired.
Sure, yes. So our client navigators essentially are the first point of contact for new referrals, and we'll re-engage with our clients throughout their rehab journey because we are a lifespan service provider. So once we receive the information, typically from the ophthalmologist or optometrist, are our primary referral sources that can also share diagnosis and acuities and other relevant information to help us customize the rehab treatment plan. We've also opened it up to allow for self-referrals, family caregiver referrals, and community referrals. So when that information is received, the client will be contacted by our client navigation team, who will conduct an interview and really try to identify what are those key elements that they're experiencing in their life, so that we can customize the next steps of their journey within our rehab team. And in some cases, we will also support with navigating beyond our services into other community programs, depending on how that interaction and that interview goes.
Next here is primary service provision. And the majority of clients will be assigned a primary service provider who completes a comprehensive functional low vision assessment in order to determine their current visional level. So we understand, particularly when the clients are coming from hospital, they may not have had the chance to have an ophthalmology assessment, and you may not have detailed visual information, but that shouldn't deter you from making a referral, because the first touch point is going to be completing that functional low vision assessment. In this primary service provision area, we also provide therapy that addresses the most common and the least complex issues related to vision loss. Clients who need more than that would go into a specialized service provision. And those are generally clients with the more profound vision loss, perhaps ones who have more complex needs, or they're ones that would want to achieve a higher level independence. So for example, someone who really wants to be able to mobilize out into the community is going to be needing extensive orientation and mobility services. So they would move into the specialized service provision. Again, someone who perhaps wants to eventually return to work, or be able to use their computer with a lot of confidence, then again, they could go into one of these specialized service provision pieces, and they could work extensively on learning how to use their computer, perhaps even learning how to read using Braille. So in this one, the therapy is quite tailored to their specific needs. And really the goal is to attain that higher level of independence and whatever their maximum kind of ability is. The top two levels are more specific, and this is generally where stroke would fall into. And its specialty programs here are things like falls prevention and stroke, rapid response, we're calling another program. So it's really for clients with more urgent needs. Usually it could be things like a significant traumatic vision loss, maybe it's a car accident, maybe it's a stroke, but they've lost that vision quite suddenly. It's impacting their participation in the rehabilitation. So for example, you think about speech, client would have difficulty participating in speech and language pathology if they could not actually see the printed word or pictures. And so the ability, they may need that functional low vision assessment to provide them with magnification or something like that in order to allow them to participate in SLP. This is also looking at a rapid response because someone's in the hospital, they need to go home. How can they receive care quickly? Some sort of conversation needs to happen to be able to figure out how soon vision rehab needs to come in and what that client needs in order for them to be able to go home or participate in rehab. So overall, what do? Our main core services are vision rehabilitation. In that vision rehabilitation, we do comprehensive functional vision assessments. We develop individualized rehab plans, and we provide one-on-one therapy, sometimes group therapy as well. For example, I refer to a falls program. That's a new program that we've developed, and we've spoken to some people in Timmins about potentially running one there, where it's a group falls prevention program to address those issues that are specific to vision loss, and so that we can reduce falls, which are higher in this population, so we can reduce falls overall. We also provide, as Carrie explained, client care navigation. We have an interprofessional team, and we coordinate service amongst that team, but we also coordinate and partner with external providers. What's challenging to sometimes understand for those who are not familiar with the type of care we provide is that we have a variety of healthcare specialists or therapists that have different training and different certification. So all of them are involved in that rehabilitation process. So these are low vision therapists, and we're going to explain what each one of them does just to give you an idea, but there's listed here. So low vision therapist, a vision rehab therapist, an orientation mobility, assistive technology, occupational therapists who have training in or specialty in low vision, and then a new and emerging role, which is service coordination. I'll let Carrie deal with low vision. She's definitely more experienced on that than me. So
in reference to our certified low vision therapists working throughout the Northeast region, we work to strategically locate them in one of our 3 offices in Northeastern Ontario. We have an office in Sudbury, one in Timmins, and one in Sault Ste. Marie. So we will deploy them to conduct the functional vision assessments with individuals who require that service. And in many cases, the assessments are conducted in one of our offices, but then we also recognize the value of being able to assess the client in their living environment, and bring to their attention some strategies to incorporate in their homes and in their daily lives that could help them maximize the residual vision that they have, and also introduce them to aids and devices that could enhance the remaining vision. Specifically talking about magnification, lighting, some positioning of things in the home environment, also looking at where they might benefit perhaps from some tactile indicators just to reinforce if they're not able to see everything clearly. So it really is a starting point for any clients who do have remaining vision. And these assessments really help them understand beyond their diagnosis, kind of, okay, now what does this mean for my regular routine and daily life? We also try to include key members of the family or the caregiver support team. It's really beneficial to at least have one additional person involved so that that reinforcement can carry on through that. It's hard to retain all of the information in a short period of time. So we like to reach out again beyond that. So this next slide does highlight some of the skills that are addressed and some of the devices that might be introduced. One of the other features that to reference with our specialist physicians is that they are all authorizers for the Ministry of Ministry of Health Long-Term Care assisted devices program funding. So through an assessment that gets conducted, they can identify aids and devices to support the clients and complete the paperwork process, so they could be eligible to receive subsidy for the purchase of aids and devices, which do tend to have a very high price point. So this is very useful in Ontario.
yeah, that's great. Okay, so our next group of clinicians is CVRT, which is a vision rehabilitation therapist. Oh, Carrie, you're doing a great job. Why don't you keep
Sure,
going?
no problem. So essentially, these professionals will support our clients with all activities of daily living from the time they wake in the morning to the time they go to sleep, and instruct them on how to do things in a different way to accommodate their visual needs. So there's a full range of clients and age groups that will be introduced to this particular area of rehab. So Teresa mentioned earlier, if somebody is interested in learning the Braille code as a method of communication, this is the specialist that would engage with them to teach them the Braille code. They will also look at different strategies in the home to make any adaptations for either sight enhancement or sight substitution strategies. So where might we incorporate magnification and lighting, and where might we incorporate some tactile indicators or some voice indicators. So if they need to rely more on their touch and their hearing to manage with meal preparation, self-care, home maintenance, and all of those other activities of daily living.
Our third one, which is quite a specialized area, is called the COMS, a Certified Orientation and Mobility Specialist. And they're quite unique. And Carrie, why don't you continue?
Sure. So orientation mobility specialists will, again, conduct an assessment and determine the rehab goals with the client to identify what are their limitations for getting out and about where they need to go in home, in community, and other destinations on their list. So an orientation mobility specialist may introduce mobility cane. And the mobility cane most often appears as a white cane with the contrasting red at the bottom, and it is traditionally measured from the client's shoulder to floor when they're standing upright to allow the cane to protrude in front of them about 1.5 paces to 2 paces, depending on how quickly the individual walks. And essentially it's to identify any hazards that are in their path and how to navigate around those obstacles safely. There are other mobility devices that could also be introduced, a support cane. Basically, if there are some issues with the client's ability to just walk and stand and they need that support, but it would identify them as somebody with sight loss because of the color of the cane. And the third cane is an identification cane, which is much thinner and shorter. It measures from wrist to floor when standing upright, and it can be tucked away and pulled out as the individual requires it, just to reassure them about potential hazards in their path or to identify themselves as somebody with sight loss in a crowded or busy environment. Learning how to use other forms of transportation is another big part of the orientation mobility specialist role, as many of our clients are having to relinquish their level of independence with being able to retain a driver's license. This is a really tricky piece to navigate with an individual because it does tend to also have a huge emotional impact. But looking for those other forms of transportation where they are available and recognizing Northeastern Ontario, there's pros and cons when it comes to alternative forms of transportation to get to where you want to go, because not every community has public transportation options. So the orientation mobility specialist will also work with caregivers and other community partners to help them understand the technique of sighted guide. And that could be very beneficial for the clients or the patients that you're working with to support them in unfamiliar environments or whenever the environment is just diminishing whatever visual ability they have at that time.
Thanks, that's great. The other piece that's particularly important for clients potentially at the beginning or when they've just lost their vision, is that they may be uncomfortable or unsure about using a cane, but to recognize that there are other skills that predate or come before use of the cane, and those can be done early on. Things like learning how to localize oneself in space, how to protect yourself when walking, things like that. The next one is, I'm not going to talk about too long, but it's the assistive technology specialist. Most of you would be familiar with that for different disability. So we have specialists who would assess and work with the client to identify what type of technology they might need. in addition to magnification, things like computers or smartphones, tablets, that kind of idea that would help. And again, these are authorizers through ADP. So they are able to fill out that paperwork and send it in on the client's behalf. And apparently we're not, oh, there we are. There's the pictures. So just some visual pictures as some visual representations of the different types of technology. So for example, we've got a tablet here where we're using it not through sight, but through sound. This one is picking up what's on that paper and projecting it onto a larger screen or onto the wall. This one is an example of using a Zoom text, which is software that enables the font to be quite large, and you can do things like changing the background color, the color of the actual text. And then this is a Braille reader where they're actually reading what's on the computer screen by continuously refreshing Braille that pops up and down. So there's an interesting way to access a computer. Occupational therapists, it is an area that is slowly growing within the low vision field. In the US, it's much more known, the same within Australia. But the OT who works in low vision is someone who has the ability to combine their knowledge related to physical, cognitive, and mental health along with those vision pieces. So it could be looking at some of the areas that other members of the team are addressing already, like the getting dressed or being productive within the home, but they could also include those more physical or mental health components. So for example, mobilizing transfers is a good example, where they would be able to consider what sort of physical limitations that client had along with their visual limitations. They're also good at doing home safety assessments or accessibility assessments related to vision loss. Another role that is slowly developing there is called a service delivery coordinator, and it's a recognition that with these clients who have more urgent or needs or potentially more complex needs, that our organization needs to be able to rapidly respond and potentially deal or talk directly with the team in the hospital or the specialty team in the community. So we're looking at someone with a very strong clinical background or training who's able to have that conversation with the other healthcare providers and come up with a plan, a treatment plan on when and VLR should be integrated or what types of coordinated response we can do. Behind that, the idea is that potentially having a small team that can address these very specific and complex needs across the province. So let's talk about how stroke or vision rehab can be integrated into the stroke rehabilitation that's already occurring. It really is consistent with Canadian stroke best practice, although Canadian stroke best practice doesn't typically list vision as one of those issues. It does talk about discharge planning from inpatient care should consider significant changes to function and identify barriers to integration. Well, vision loss is certainly one of those things. And it does need quite specific safety, quite specific equipment and modifications. So that would indicate that it's a good place for vision rehabilitation specialists to be involved in the team. As well, when we look at transition planning back to the community or even between rehab units, we can focus on things like caregiver training. We can focus on helping the client access the resources that are appropriate to their vision loss and improve that patient's independence. Again, all those things are consistent with Canadian stroke best practice recommendations. So where does VLRC fit in? We are a very unique organization in the sense that we are a freestanding community organization that provides rehabilitation, but we are fully funded. So we're not associated with a particular hospital. We're not associated with home and community care. We are separate from both those places, but we are funded to provide care along the full continuum because of that. So we can go into inpatient rehab if we need it, and it's appropriate, and the hospital's in agreement. We can certainly be involved in that discussion around discharge planning, and we can also work with the team and be integrated in the team in terms of home care and community care. Sometimes, it allows for those early acute referrals where we can share some information, we can do some consulting, we can discuss that rehab plan, and maybe allow that clinician who's in the hospital or rehab center to bounce some ideas and figure out how to approach the needs of their clients. And lastly, because vision loss doesn't tend to be a one and done, it continues to be there for the remainder of their life, and oftentimes it will change over time. We can be an ongoing resource for that client, so they can self-refer themselves back in for further care or treatment if it's needed later. So then we're involved in the late stage recovery, or potentially when they're trying to return to work or school at some point. There are several ways that we've touched on in terms of how we can work together. One is collaboration. So can we collaborate with that rehab team in the hospital? Can we do joint visits? Maybe we've done joint visits, for example, with home care OTs, where we've gone in and we've looked at everything in the home from a vision perspective, and they're looking at it from their regular home safety assessment perspective, and we're sort of marrying that information together to come up with a more appropriate plan for that client. As I said, we can consult, we can help adapt the way in which you're potentially providing care. We talked about SLP, but we didn't really talk about physio, and that's also one of the areas where, for example, one of those orientation and mobility specialists might have some really great methods or input into how to work with that client as they're regaining their gait. And so they could have some great joint sessions potentially with the physiotherapist, or at least consult on it. Coordination, again, coordination of our visits, coordination of care plans, whatever that coordination looks like. And lastly, rehabilitation. We are direct providers of rehabilitation specialty care. So that's sort of the different areas that we can work together. Carrie alluded to the fact that it used to be that we mostly got referrals from optometrists and ophthalmologists, but in recognition that there are many others within healthcare that are going to see those vision issues, we've opened up our referral basis. So now anyone can refer to us. It could be a client themselves, it could be another health professional. I personally have had calls from social workers in the community saying, I just met with this client and they're having a great deal of trouble doing their banking. Can you come in and work with them? Absolutely. Send us a referral. We'll go in and do that. Although we'd prefer it, we don't need a visual diagnosis or an assessment. So what that means is often in stroke, other team members, OTs, PTs, etc., will hesitate to refer the client because they haven't been assessed by a neuro-ophthalmologist. And we all know that it can take some time to get in to see a neuro-ophthalmologist. And by that point, the client has missed those first few months where they could have potentially had some intervention related to their vision. So we are saying if you're seeing a functional problem and you're recognizing that the clients potentially have some problems with their vision, then you can refer them and we can go in and do that functional low vision assessment and get a sense of what is going on. The client would still go to the neuro-ophthalmologist. We just might be able to start that care before we get a more specific issues identified. So you can go, anyone can go to our website. There's the link right there. You go to where, if you're a healthcare professional, you go to that piece and then you can fill in a referral. If you happen to know the name of the physician or the ophthalmologist that's working with that client, great, put it in. We'll follow up and get the information. Or if you have a discharge summary or something that gives us a good sense, you can also attach that if you would like. What we really, really need is we need the reason you're referring the client, what sort of functional problem you're seeing in terms of their vision, the time since the onset of the vision loss, whether it's a new sudden vision loss or whether it's something that was ongoing, perhaps it predated the stroke, where that client is. Are they home? Are they still in the hospital? Are they in the rehab center? Where are they? And then your contact information so that we can follow back up with you to either coordinate care or just to get more information if we need it. Once you refer a patient or a client to us, and this particularly, I'm referring to the ones that are coming from the hospital, our team will reach out to the referral source or that discharge coordinator directly within 48 hours, meaning 2 business days. So not all clients are we going to reach out to them within 2 business days? We're talking about the clients who are flagged on that referral as being an urgent, they're in the hospital, something's triggering us to call and follow up quickly. We'll work with the referral source to determine the needs of the client and to figure out how we can work together. As we've said a couple of times, services can be delivered in lots of ways. And so there's no set pattern to how it's going to happen. We could potentially go into the hospital. We could potentially see the client as soon as they're discharged home. We could potentially be doing some consult up first and then scheduling the care afterwards. There's a variety of ways. What I do want to emphasize is that along with referring them, you don't need to know who you're referring to them. So you don't have to say, I'm referring them for orientation and mobility. As Carrie was talking about our navigation piece, we recognize that not everyone knows all the different types of service we provide. So that's part of our intake process, is to figure out the types of service that client needs. I have a couple of case examples, which I'd like to just sort of go through quickly, and then we'll open up for some questions at that point. So just to give you a couple examples, these are stroke examples. So this is a client who was in Eastern Ontario, 46-year-old woman who had an ischemic stroke, which affected primarily her vision. There was a lot of change to her vision. So acuity, contrast sensitivity, field loss, color perception, all of that was impacted. Client could not go back to work. They even had trouble completing their activities of daily living. They had trouble mobilizing outside the home. They were dependent on their spouse to be able to go anywhere outside of the home. And even inside the home, they were really dependent on the spouse for everything. They couldn't prepare a meal. They couldn't do any laundry, get their clothes ready, anything like that. Unfortunately, although the rehab team did suggest to the client our services, they weren't able to explain it in a way that the client could understand it. And the client refused it and absolutely said, no, I don't need to go to that. If I ever need anything, I'll just get myself a guide dog. It was the spouse that came to us. The spouse said I have to go back to work. I can't stay here. How are we going to manage this? And the spouse reached out to the rehab team and to our rehab team and asked if we could potentially work with that client. So, there's 3 months of them sitting at home, getting some rehab, but nothing related to the vision when their primary deficit was actually vision. So some of the things we started working with that client was we talked to them right off the bat. We had explained our services, what we could do, how we could potentially help their spouse in terms of caring for them and freeing them up. And the client was then in agreement and understood the process much more and began to engage in the therapy. Another one is a very good success story. It was a 50-year-old woman with a hemorrhagic stroke, hemiparesis, visual field loss, contrast sensitivity, visual fatigue, along with some physical issues as well. She participated in a good stroke program for more than a year. She had full rehab. She felt like it was a good rehab program. But at the end of it, she still was unable to read. She couldn't tolerate light. She couldn't use a computer, etc. So she self-referred to us. And I've got Sobers here because that's our partner organization in the Kingston area. With intervention, with a functional low vision that identified the field loss and the contrast sensitivity, etc. And then teaching that client how to adapt, working with her to change her settings on her computer, etc. 6 months later, they had gained enough ability that they could read a speech and present it via Zoom to a large audience, and they were so excited and so pleased to be able to do so. That's the end. We put our generic contact information here. If you, for some reason, want to speak directly either to Carrie or myself, my email's in the chat. Carrie's put hers in. It's our first and last name and at vlrehab.ca.
Great. Thank you, ladies. That was a lot of information, great information. If anyone has any questions, just put them in the chat and I'll relate them. You can also unmute if you'd like to ask the question yourself. I do have a short evaluation for the session and I've put the link in the chat. If you can click on it, it'll take you like 1 minute to fill out. We would really appreciate it, and I'll share a summary of the results with our speakers today. Remind you to put your email in the chat, especially if you're in a room with more than one person. Put all the emails and we'll make sure that you get a copy of a certificate of attendance for this session. As well, I'm going to get a PDF of the slides from today and I'll send that out to you as well. So I'll just start off with a few questions that I have. One was around referring and self-referring. So you did say that specifically people can self-refer now and the referral can be found online at your site. Is that correct?
Yes, yeah. So they can, either the health professional can do it online, but the client can also do it online as well.
Right. Okay,
Or they
perfect.
can do it by phone because some clients with vision loss aren't able to use their computer. So
They can just call. Okay, perfect.
Sorry, I just also wanted to mention that there is a link where you can get a 1-page PDF version of the referral form if you choose to print it off in hard copy.
Oh, okay, great.
And there's a fax number to address it to, but the way that the website is designed, you can actually submit and it securely uploads it into our system for processing.
Perfect.
yep, and it directs it to the right region and office. So it's all triage behind the scenes.
Okay, all right, perfect. And is there handouts that we could give to our patients?
About us, about our
Yeah,
organization.
about your organization, yeah.
So we're just in the process of updating them.
Okay.
We actually should have some out hopefully in the next month or so, because our old brochures, etc., were outdated. So we're
Okay.
just in the process of creating new ones.
And we'll be able to access them online at your site?
Yep, or there'll be electronic versions that we can email as well. So.
Yeah, okay, that's great. And a question around assessment. And so do you have a recommendation for when our patients are in hospital in acute or rehab, what assessment you would recommend people use for this vision loss post-stroke that isn't picked up on? Like we do hemianopsia and those things, but is there some other form of assessment we could be doing as therapists?
Yeah, and I can send that information to you. There is an assessment tool that's been developed in the UK. It's called VISA, Visual Impairment Screening Assessment. It's intended for neurological injuries, so stroke included, but any head injury. And it's relatively short. There's a YouTube demonstration of it as well that you can watch, and I'll send that link as well. The idea is it screens for a variety of different vision issues.
Okay. All right. So if you send that to me, I'll include that in my mail out to the participants today. Thank you. Should all stroke patients see an optometrist, and how soon? So I know when we get our patients' experiences in inpatient rehab, we don't necessarily send everybody to an optometrist. And is that something you feel would be required?
I don't think certainly it's not in the stroke best practices. And I've been doing a lot of research in this area in the last 2 years. It's not generally an optometrist that's needed. So unless they clearly need glasses, there's only a very few optometrists that are low vision optometrists, and they have long wait lists. I don't know whether Carrie has the list of any potential low vision optometrists in the north. That's why we're looking at doing this screening for the low vision by the team, referring them to ourselves, and you would generally want them to see a neuro-ophthalmologist if there's any issues that are identified at that point.
Barry, do you know of any low vision optometrists in the north? I feel like there's somebody with some skill in North Bay, but I'm not positive.
I was also aware, but I haven't explored to see if they're still practicing. One of the other added benefits within Northeastern and Northwestern Ontario, actually housed in our Sudbury office, is the home base for the Medical Mobile Eye Care Unit, which we nickname fondly the IVAN. The IVAN is on tour through several months of the year, and there are ophthalmologists that are associated with it to help meet the eye care health needs of a lot of communities that don't have access to ophthalmology, and in many cases optometry either. So we do recognize that the number of professionals in Northeastern and Northwestern Ontario are few and far between. Right now, there seems to be an additional added crisis where some of those that have been practicing for a great number of years are ready to retire, and there's not really a strong succession plan in place.
Right.
So we do rely heavily on many communities rely heavily on the IVAN tour to support that primary care piece for their vision health. So as far as the optometrists that do and conduct low vision assessments, yeah, as I said, I believe there was one in North Bay. I'm not sure if they're still practicing, and I think there might be somebody in Sault Ste. Marie too, but I can tap into my colleagues just to confirm that.
And if
This
people want
is something else that's a little different than stroke, but cataracts. Normally, we don't work with cataract patients because they're because they're getting their surgery done quite quickly, and so they don't have issues really. But the wait list, particularly in the north, is quite extensive now, and sometimes that wait list is up to 2 years, 500, 600 days. And so they're actually experiencing functional problems and functional decline. So you may want to look at, if you see clients with cataracts, consider the idea of referring them through to us as well, because some of those clients are not being identified because they're just sitting on the wait list and not being identified as having functional problems that'll go on for quite some time.
Right. And is there a way we can access where the IVAN is in the north?
So the referrals come through the IVAN program, and actually we could set up a separate conversation with the general manager for the IVAN program. I could share with you the list of destinations. The tour is pretty full. I think they see more than 4,000 patients throughout the tour. That starts off actually they started off in Cochrane. And they loop all the way around. I know that they've included more communities this year. Of course, during the COVID years, there were some significant modifications to the tour.
Right.
But they are looking at getting back to full steam ahead with more and more communities. But then there's also the added challenge with having the ophthalmologists available to commit to certain communities. But it's a transport truck, and the trailer of the transport is actually a functioning ophthalmology clinic where some minor procedures can take place. So there's a lot of follow-up that takes place on the IVAN just to monitor on an annual basis some people that are at risk. So yeah, I'll share with you the tour locations and dates. I can send that in an email.
That's great. Thank you. I have a question from Kathy. She's met a patient who suffers from a hemianopsia, but also cognitive impairment from stroke and some underlying dementia. This vision loss is certainly very disruptive to her. Would your team have the capability to work with the family to implement strategies, even if the patient herself may not be able to learn the strategies?
It depends, but yes, I mean, we do work with the families, for sure. It's not always necessarily successful, just as it won't be successful for lots of issues when there's a significant cognitive decline. So like they won't remember and have to be cued. But if the family is willing to learn cueing or learning how to adapt the environment to make things better, absolutely.
Yeah, and it's sometimes too, there's some different leisure activities perhaps that we could support the individual and the family members with if they want to listen to audiobooks, magazines, things like that, how to, again, adapt things in the environment to make the level of risk perhaps a little lower. Just incorporating things like high contrast of color, if it just there's some additional attention that needs to be made when they're trying to do some independent activities.
Mm-hmm. Great, thanks. I know in the past, working on rehab, we used to refer to the CNIB. And so do we still continue that referral? And will they also refer us to you, or do we refer to you guys? Just you guys now, or how does it work?
It's better to refer to us.
Right.
If during our intake we recognize that there's something that CNIB can offer to the client, we'll just refer them over to the CNIB.
Okay. Perfect.
So CNIB has things like programs to support clients, peer support programs. They have, things like that. They also have some equipment demonstrations, different types of programs, not direct medical care. So it's better to go the other way, to come to us, and then we'll connect them over.
Okay, perfect. Thank you. Thanks. So we're 1 minute over. I'm going to wrap us up. Thank you for everyone for joining us today. I will be putting this recording up on our YouTube channel at the Northeast Ontario Stroke Network for people to access. Special thank you, Teresa and Carrie, for joining us today, sharing your time with us and your extensive knowledge. I'm really excited to hear how much you do, everything that you incorporate, and I'm sure you'll be starting to receive some referrals from the Northeast in the near future. So thank you again for joining us.
Great. Please feel free to reach out to either of us if you have a question.
I will. Thank you.
Great. Take care. Have a good day, everyone.
I know.